Evening, everybody. It's now 8 o'clock, and as those of you who've been listening to the pre-conversation will realize that we've got to get a move on, definitely, because of the time change. This is already very late at night for an Israeli speaker. That's one reason why we're grateful to Ora for coming along tonight and talking to us. The other reasons are, of course, is that she's been an outstanding a leading figure in several aspects of Israeli medicine for many years, and she needs very little introduction here because she's spoken on the COVID-19 series before, but in addition to which, she's spoken when she was on sabbatical here in what seems like an age ago before COVID-19. I'm going to hand over to her because she's the person you want to hear talking about the COVID-19 epidemic in Israel. Lessons learned and cautionary tales is her theme. I noted that in her blurb, she's referred to the first, second, and third wave. And this seems to be an indication that there's a degree of prophecy also that's going to be coming out tonight. Look, Ora.
Well, thank you very much, David, and thank you for participating tonight. I don't know if it's a pleasure to be telling you this story or whether it's a tragedy. I think that we don't know yet what the ultimate outcome of this pandemic is going to be in any country, and let alone in our little country of Israel. But I think that we do have some cautionary tales to tell. So just as a way, I can't move my slides. Okay, I'm just going to introduce myself briefly. So my name is Ora, and I was born in Canada, and I grew up in Canada and trained there in medicine, and then moved to Israel in 1992. I'm an internist and a hematologist and an epidemiologist, and the former director of the School of Public Health at Hadassah and the Hebrew University. And then none of that qualifies me to be an expert on COVID. And yet we've all been recruited somehow to give our expertise. And I guess one of my expertises is looking at data. And I think that there is a lack of people who understand data and who can explain data to lay people and who can translate data into policy. So I guess that's what I've been recruited for during this COVID epidemic. I do not directly take care of COVID patients, so I don't have much clinical input here, but I do still try and take care of my hematology patients. I just lost a lymphoma patient to COVID in the last week. So it's very, very real to us. I have no disclosures in terms of commercial conflict of interest. So what I'm going to talk about tonight is a little bit of a description of what the COVID epidemic or the SARS-CoV-2 epidemic looks like in Israel thus far. It is a work in progress, and as I said, we don't know how it's going to end and when it's going to end. And I'm going to try and put it in perspective and in the context of the healthcare system in Israel, the political system in Israel, and our culture and demography, a little bit of comparisons with the UK. I'm going to talk possibly somewhat provocatively about the management of the epidemic in the context of our society and its governance. And I know that that is a big issue in the UK as well. One of the issues that I've been very, very involved in Israel is the issue of children and COVID, and especially policies regarding school closures and school openings. So I'm going to talk about that. I'm happy to take questions and complaints at the end. On this very first slide, I'd like to show you a picture of Aryeh Even, who was the first victim of COVID in Israel. And the reason that it's important to show his picture is that, first of all, he was 89 years old. So that's the age group that we know is at high risk of mortality for COVID. The second thing is that he was perfectly functional. He was living in the independent section of a sheltered housing apartment building in Jerusalem, not far from where I live. The third very important thing is that he was a Holocaust survivor. So there's something very symbolic about the fact that the first victim of COVID in Israel was a Holocaust survivor. And I'll get back to that later on. And the fourth thing is that we know his name. We know his name, and we don't know the names of many other victims of COVID, because at the beginning, not only was there novelty, but there was a personal connection to people suffering from the disease and people dying from the disease. And nowadays that seems to be disappearing. We seem to be hearing individual stories less and less. A famous actor died this week, so we know about him, but we know very, very little about the individuals suffering and dying from this disease. I'm not sure if that's true all over the world, but certainly true in Israel. So Aryeh Evan, first victim of COVID in Israel. I would have liked to be able to tell you this tale, which is the tale of the first wave in Israel. I could almost say a cute little wave that had a few hundred victims. Aryeh Evan was one of them. And it had many hundreds of thousands, if not millions of victims because of the management of the first wave, because it had grave social and economic consequences. The second wave happened sort of under our noses, and not much happened during that second wave, except that we got used to having quite a few cases of COVID and diagnosed every day, and people being admitted to hospital, but it never was a surge. It never overwhelmed the healthcare system, and we grew accustomed to living with COVID for a good 2 months, from the middle of June till the middle to end of August, and with quite a few cases per day, but no great panic. And then we had this third wave, and that's why, David, I call it third wave, even though some people think that we're still in the first wave, because the management of the three phases was very, very different. So you could say we've had two waves, you could say we've had three waves, you could say we've had one wave, but I think that there is definitely a difference in the shape of these epidemic curves. And here we're talking about cases per million, confirmed cases per million, and not deaths. And as you can see, the number of confirmed cases per million has gone down quite drastically in the last couple of weeks. And these are updated up until 3 days ago. And now we're at about between 400 and 700 cases per day. Okay, so let's look a little bit about what our country looks like, what our healthcare looks like, and how we can compare it to the UK. So we have similar life expectancies, a little bit higher in Israel for men, a little teeny bit higher for women. One major difference between the UK and Israel is the percentage of population above age 65, which is almost 19% in the UK and only 11.3% in Israel. And I think that's very relevant for our mortality statistics in this COVID era. Life expectancy above age 65 is about the same. And given the difference in the number of older citizens, our old age dependency ratio is quite a bit lower than it is in the UK, and that will impact the number of people that require long-term care, obviously. Israel and the UK both suffer from a lack of physicians, you more than we, and a lack of acute care hospital beds per thousand population. The Israeli healthcare system, for some magical reason, takes up less of the GDP than the UK, the NHS. That's been something that people have been very proud of in Israel, that we have good health outcomes despite spending so little money on healthcare. I'm not sure that as time goes on, that we agree that it's something that we should be proud of, because there are definitely faults and lacks in our healthcare system. But one thing we definitely do have in common as a society is that we believe in health as a right, and we provide universal health care coverage for all of our citizens. And I think that's also very important and relevant in the times of an epidemic or a pandemic. And these are our population sizes, that just so that if I talk about absolute numbers, you can multiply them by 7.5. Okay, what about the makeup of our population? So in Israel, about 79–80% of the population is Jewish, and of the Jewish population, 67% are either secular, religious, or what they call traditional, and 12% of the population is what we call ultra-orthodox or Haredi. And this is going to become very relevant when we talk about who's gotten sick in Israeli population. 21% of the population is Muslim, Christian, and Druze, mostly Arabic-speaking population. And this is in comparison with the, I don't have a graph for the UK, but the English population, which is about 80% white, and then a mixture of Asian, Black, and other ethnic groups. One very, very striking difference between our two countries is our population pyramid. So Israel is a very young country with a huge, huge, huge amount of children, and a huge amount of young children. We have pronatalist policies which encourage birth and high fertility rates, and we also have religious groups in which high fertility rate is considered a blessing and even expected. And so you can see that, relatively speaking, we have this very broad-based population pyramid with a very small peak of elderly population. Oh, I'm not sure you're allowed to say elderly anymore in the UK, so older adults, as opposed to the UK population, which is much bigger around the middle and has a much narrower base of children. And this is very, very relevant when we're going to look at mortality rates and also the burden of disease. So what do we know about the response to the pandemic in Israel? So I think the first fear among opinion leaders and decision makers in Israel is the fact that our bed occupancy rates in acute care hospitals are very, very high, and very high compared to the OECD average. This is around all through the calendar, but becomes much, much worse in winter. So when we have flu and pneumonia and other respiratory viruses, typically internal medicine wards in Israel are at 125, 150, even 160% capacity. Emergency wards are overflowing. And to go into a pandemic, especially a respiratory disease epidemic, with those kind of occupancy rates is quite daunting and frightening, I think, for any healthcare system. Relatively few ICU beds, about 4.2% of the beds. But having said that, Israeli hospitals are used to ventilating patients who are not in ICU beds. So it's not uncommon to see ventilators in a regular internal medicine floor. It also means that the internal medicine physicians and nurses are trained and skilled at taking care of ventilated patients. And that probably means that you have a kind of hinterland of almost ICU doctors or almost ICU nurses who could take care of a surge when that happens. So this is the number of ventilators that we had at the beginning of the COVID epidemic. Only 708 were in use, a bunch were not functional, and we had spare number of 1,400 ventilators. Very, very quickly, the government ordered thousands of ventilators, which we know now that most of them have not been used. We never were lacking in PPE. That never seemed to have been an issue in Israel. We never saw the hospital staff being infected because they didn't have PPE. We did have a temporary shortage of reagents and swabs for PCR testing around April. And that was an issue because we couldn't keep up with the number of tests that we wanted to do. As I said, many ventilators were bought. I don't know how many. I think it's probably a state secret. What I've heard is that they're trying to sell some of them. So I think that there was an overshoot in the number of ventilators that were ordered. Some training courses were done for MDs, especially regarding night call. So gynecology residents, surgery residents, orthopedic residents were taking call at night in COVID wards and had to be retrained for respiratory care and ICU care. And then during this last wave, where it looked like we actually might be overwhelmed, the IDF, Israel Defense Forces, built two field hospitals in the parking lot. You can still see the signs of the road here in the parking lot of Rambam Hospital. And these were for patients who were not critically ill, but moderately ill. One thing that I don't have on this slide is that Israel, probably like many other countries or almost all countries, had in the drawer all kinds of pandemic response plans and teams that were supposed to take care of pandemics. But these plans, I don't think, ever made it out of the drawer. And the teams that were trained for many, many years in terms of policy making during pandemics have played a minor role in decision making during this, during the management of this COVID epidemic in Israel. So Israel has a nickname as a startup nation due to its innovation in high tech and biotech. And I would venture to say that we are becoming the startup nation in this second or third wave because Europe seems to be following close behind. I think Belgium is having a terrible second wave right now. But you can see that we were a little earlier and we're already coming down, and these other countries. And the reason that I have Belgium and Austria here, sometimes I have Sweden to compare with, and these are data from the Our World in Data website, is because they are a similar size to Israel and United Kingdom, just to keep you interested. So we have this early wave, if you wish, we'll call it the second wave. It started in September, and it peaked very, very rapidly. And we had some days that we had over 9,000 cases per day, which is very, very high given the size of our population. What about deaths? So far in deaths, we're not leading, which is a happy situation to be in. For the first wave, we had a very, very low death rate, lower than Austria, much lower than Belgium, France, Spain, Sweden, of course, United Kingdom, United States, much, much, much lower death rate. And when I spoke to this organization a few months ago, one of the questions that was asked was, why do I think that Israel had such a low death rate during the first wave? And the only two possibilities that seemed plausible to me were that we never overwhelmed our healthcare system in the first wave and that we have a younger population. But you can see that with this recent wave, call it either the second or the third, I like to call it the third, we have surpassed Austria and we have surpassed the world average. And we've had 845 deaths in October. So definitely this last wave has been more lethal. In terms of testing, at the beginning, I think that we were lagging in testing, and our public health authorities seemed to be giving the message that testing was not all that important, and that what we had to do was stay home and obey the measures that were being wrought by the government, and obviously keep our distance, etc. But with time, it became obvious that testing was very, very important. And it became all the more important when the numbers of cases rose to 1,000 a day and more. And then the tracing methods and the epidemiological investigations were not able to keep up with the number of new cases per day. So I think that Israel is doing pretty well in terms of testing capacity. And we do this by having labs in all 4 of our HMOs, in all of our hospitals, and also a private lab called MyHeritage, which usually does saliva tests for people who want to know what their genome looks like and who their relatives might be. That has been repurposed for PCR testing, and especially for screening in old age homes or in care homes. We have these freestanding facilities that are spread all over the country that are run by the HMOs and also by our ambulance services who've done a huge amount of testing in these drive-in clinics. Most of the testing is still PCR testing. We recently have acquired a bunch of Sophia machines. We're not sure how relevant they are actually for controlling this epidemic. And we also have serology. Okay, the big question that I was asked last time was about excess mortality. On this graph, I have England and Wales, 2 age groups, 65 to 74 and 75 to 84 throughout the whole epidemic. And you see this big surge of excess mortality up to 120% above the 5 previous years in the age group 75 to 84, and almost 100% in the age group 65 to 74 in the UK, whereas we did not really see that in Israel. But you can see now, starting at the end of September, that we're starting to see about 20% excess mortality in the 65 to 74 age group with this recent wave. And we're going to have to wait maybe a few more weeks to really see the results of this wave. But I don't think that we're going to get away with no excess mortality this time around. It's not going to be a huge surge and peak like you experienced, but it will definitely be there. And it's going to be in this age group 65 to 74, meaning that these are people who are younger than people you would expect to be dying, especially in the late summer, early fall months of the year. One of the big issues around the world, especially in Europe and Canada, and is the issue of nursing home deaths. So in Israel, about 1/3 of the deaths have been in care home residents or nursing home residents. And that's quite similar to several other countries, maybe a little bit less than England and Wales, and much, much less than in Canada. And part of the reason for this is probably the fact that we have fewer of our older population in care homes, and many people who need long-term care are actually cared for at home. And when they're cared for at home, they have one caregiver, so they're less exposed to a large workforce of care home staff. And so I think that has protected the older population in Israel quite well, although I don't think we can be proud of 30% even of care home deaths. The other thing that has protected the older population in Israel, especially those in long-term care facilities, is this program called Magen Avot V'Imahot, which means shield or protect our fathers and mothers. And this was a program that was instituted during the first wave, when it was clear that there were several institutions that had deaths in the double digits, so 14, 15 deaths. Aryeh Evan, that the first victim who I showed you, I think 16 people died in that institution that he lived in. Many of them were independent, folks who had full activities of daily living, but they had been visited by a social worker who it turned out was a super spreader and had spread COVID to over 20 of the residents in this building, of whom 16 had died. So when those events became clear, a few of those events became clear, the government called into action Professor Ronnie Gamzo, who was the head of Ichilov Hospital, and he set up this program called Shield Our Fathers and Mothers. And it was quite an efficient system. It's still going on. It's headed now by Professor Nimrod Maimon. And one of the hallmarks of this program is regular testing of the staff. I don't think we can talk about pandemic policy, containment policies without talking about their economic costs. And it's almost a mirror image. As stringent as our containment policies are going to be, the economic costs are going to parallel them in a negative way, unless the government opens its pockets and gives money to the population. And I know in the UK that was done, and it was done in Israel as well, not very efficiently and and it took a lot of time, and it caused quite a lot of rancor, and it still does. However, it's very interesting to see that before this last wave, the actual economic decline in Israel was lower than a lot of European countries, not all of them, but some of them. So the UK economic decline in the second quarter of 2020 was, this is according to our World in Data, but I think it came from The Economist, is minus 21%, whereas Israel was minus 7.8%. I think that all that is going to change when we look at the third quarter because we experienced the lockdown in the third quarter. And one of the things that The Economist calculated, however, that there's no correlation between the stringency of the measures and the economic costs of these measures and whether there's a payoff in human life. I think that's very sobering and should make one think about the costs of lockdown before it's instituted in a rapid way, because it's not necessarily going to pay off. I mean, the worse the economy is not going to necessarily pay off with fewer deaths. Okay, now I want to talk a little bit about governance and how this epidemic or crisis was managed. And I'm hesitant to show this picture, but I'm showing it anyway because it's an iconic picture. And what it does, it shows 4 men, and this is during the first wave. And these are the managers of the epidemic during the first wave. So we have our Prime Minister showing us a screen of what happens when people cough. These are, I don't think they're viral particles, but maybe viral particles when people cough. So he's giving the population, this is on live broadcast on TV, he's giving us a lesson on hygiene, social distancing. He even showed people how to cough into their elbow. He took it very, very seriously, as opposed to some world leaders. And he was going to tell us and show us how we're going to protect ourselves and our relatives from getting sick. But sharing the podium with him are 3 other men. This is Moshe Bar Simantov, who was the Director General of the Health Ministry a young, energetic, and brilliant man who is not a doctor, who has never been trained in public health. He's an economist. And he was making the major decisions during the first wave, including the decision for a lockdown, and it was a major lockdown. Sitting beside him is the health minister at the time, dressed in his Purim best. It was a holiday time. He actually got COVID right around this time. And most of his input into the management of the epidemic was to negate the importance of the severe measures that the government wanted to initiate. And the fourth person on this podium is Mayor Ben Shabbat, whose background is in security forces. And he's the main advisor is the main advisor to the what's called the Corona cabinet. And most of his advisors are either physicists or people who come from the military. So this was who was basically running the show for the first wave. And they came down with a very strong hammer, very early lockdown, and very stringent measures, with good results in terms of very low mortality, but very bad results in terms of economic consequences and social consequences. But another consequence of the management of the first wave was a terrible lack of trust among the public for their leaders, and part of that was due to the behavior of the leaders. So here we see our Prime Minister with his son having a Passover Seder. Passover Seder is a very special meal that we have on Passover. And Passover this year, it took place during the lockdown, and the guideline, they weren't even guidelines, the rules, the law was that you could only have a Passover meal with your immediate nuclear family with whom you were sharing a residence. And actually this son of the Prime Minister lived next door, so they weren't technically speaking sharing a residence. And this picture was leaked and went viral. And then it turned out that even our president, not only our Prime Minister, shared the Passover meal with his family who didn't live with him. And I think that was sort of almost the beginning of the end in terms of public trust, because these measures were coming down from on high. And meanwhile, the public, all they saw was their own suffering, while they saw their leaders doing what was good for them. And that has continued. We've had a continuous litany of infractions of these measures by various government leaders. So what actually were these measures in the first wave? This is from the Oxford Coronavirus Response Tracker, just comparing Israel and the United Kingdom, and you can and Taiwan, which has managed this epidemic in just a miraculous way, it seems to me. So the Oxford looks at has developed a stringency index, which has about 8 elements. And you can see that Israel rapidly increased the number of measures that were in place. And by early March, was one of the highest stringency indices in the world, even higher than Italy at some point here. And Italy was having a terrible surge of cases. While we were not having a terrible surge of cases, we were just worried about this terrible surge of cases. And coming back to Aryeh Evan, our first COVID victim, Moshe Bar Simantov at one point on TV said that we have to act very rapidly and very strictly and be very, very stringent in our measures, because this is an event of Holocaust proportions. That's something that I will never forget, because to use any Holocaust analogy or metaphor in Israel is a very, very strong term. So this hammer that came down, and hammer, of course, comes from the famous blog by Thomas Puea, who talked about the hammer and the dance. So these very, very stringent measures early on. And then as things seem to be going very well in terms of mortality and case numbers, we get this very, very chaotic decrease in the stringency index, especially over a very short period of time in April and May. And soon we're going to see the consequences of that. And then you can see now that by early September, we were back to having very stringent measures again, including a lockdown. So did these stringent measures pay off? This is just one little piece of research that we're doing now and that we haven't published yet. But it seemed that border closure, which happened very quickly in Israel, did seem to pay off in terms of lives saved. And Israel was one of the earliest countries to close borders to almost every country, first to China, and then to Europe and then to other Asian countries, and then to then to Europe. But the last country that we closed our borders to was the United States, not realizing that a huge epidemic was already taking place in New York. And so many of our cases in March and April were imported from the New York area. In terms of the loosening of the lockdown, if we just compare Israel and Austria, who had similar epidemic curves in the first wave, very, very similar epidemic curves, and we also have very similar population sizes, although Austria has a higher rate of over 65s. The main difference in the management is not in the stringency of the containment measures and lockdown, but in the amount of time that it took to, and this is our own stringency index, which only has 4 levels, the amount of time that it took to go from 1,000 points in our stringency to 200 points, which is 54 days in Austria and 39 days in Israel. So we had a very rapid easing of these containment measures after the first wave. And I think that as a consequence, we saw a rapid increase in the second wave. Okay, the second wave is that blip that I showed you from June, July, and August. And what was the management of that second wave? Well, I think that actually there was no management of that second wave. And people just looked at the numbers as they were climbing to 100, 200. When we came out of the first wave, we had 20 cases per day, absolute numbers. And then the cases started to rise. And then we had a big outbreak in a high school, which was relatively self-contained, but it was huge. But after that, we had rising cases in the population. They went up to 200, 300, 400, 500 cases a day. And over the summer, 1,000 cases a day. And then we got to 2,000 cases a day. And really nothing much happened. We didn't really have any clear policy or management. We were, as they say, living with COVID. People were being admitted to hospitals. Some people were dying, but it just didn't seem to be the order of the day to be managing this epidemic. And in fact, when we came out of the first wave, our Prime Minister triumphantly came on TV and said, "You've done a great job. We've done a great job. This lockdown has worked very well. So go out and have a beer and have fun." Well, that was his message to the population. So again, first wave, second wave, and third wave, probably the most sensitive measure when we look at the morbidity and mortality is people hospitalized in moderate or severe condition, because the number of cases obviously reflects the number of tests being done, and the number of deaths reflects the number of cases, obviously, but also comorbidity, the elderly in the population. So we think that the rate of moderate or severe patients in the population is actually a good index of how well we're doing. And here you can see that that number was climbing over the summer. And this is the time that really we saw very, very little management of the epidemic, very few measures being put in place, very few consistent measures being put in place, very chaotic discussions in the government and in the parliament about how to manage this epidemic, how we're going to get the kids back to school in September, etc. And then we see this surge of moderate or severe cases in early September, and then the lockdown happened. And here you see all of the measures. The red are containment measures or lockdown measures, and the green are easing of measures. So we have school closures, masks compulsory, the lockdown, and then we have the opening of schools, partial school opening, kindergarten capsules, and then full school reopening. When I say full school reopening without any measures really in place, beaches and synagogues, then wedding halls in July. This is one of the really, really disturbing things that happen, is that wedding halls and event halls were open in June when case numbers and number of people in moderate or severe conditions were already going up. So it was already quite clear that we were facing our second wave, and yet this easing measure was put in place, and soon after that we saw a huge increase in cases. A few words, how am I doing for time? Okay, so a few words about children and COVID. As I said, there are many, many, many children in Israel. It's a pronatalist society, and children are supposedly very important in our society. And yet some of us were very disturbed as to how the initial containment measures really didn't take children into account. One of the first measures was closing of schools, and there was very, very little discussion or even thought about how schools were going to reopen and how much this was harming children. The other thing that disturbed us was the parallel that was drawn between influenza and the efficiency at which school closure seemed to manage influenza epidemics and COVID, which was something that we didn't know at the time, and we thought that was unfair and possibly inappropriate a parallel to draw. So a few of us got together, a bunch of academics, including statisticians, epidemiologists, public health doctors, infectious disease specialists, pediatricians, demographers. We even had a geriatrician at one point. We got together and we wrote a position paper on the 22nd of April about the role of children in COVID, and recommending that we send kids in kindergarten and grades 1 to 3 back to school cautiously. And we even mentioned the measures of caution that we thought should be instituted. So what happened in terms of COVID and kids in Israel? So this again is our population pyramid, and this is the pyramid of confirmed COVID cases in Israel, the proportion of cases per age group. And the proportion of children aged 0 to 9 in Israel is almost 20%, 19.7%. And you can see that if we add the boys, these are the boys and these are the girls, we get to about 10.7%. So children aged 0 to 9 are represented in about 50% in their, how do I say this? their proportion among confirmed COVID cases is about 50% of their proportion in the population in terms of population size. That is not so for teenagers. They're represented according to their population size in the number of COVID cases, and among the boys, it's even more. So we have an overrepresentation of young boys as confirmed COVID cases. 20 to 29-year-olds are also overrepresented. And until this current wave, the 20 to 29-year-olds, I would say, were the engine of the COVID infection, COVID epidemic in Israel. And you can see that the rates of infection decrease with age, with the over 90s, very, very few cases, but obviously high case fatality in this age group. If we look at deaths, and here I'm comparing to the UK, we've had no deaths under the age of 9 in Israel. We've had maybe 1 or 2 deaths of 19-year-olds, no deaths from age 10 to 18, very, very few deaths in the 20s, and most of the deaths have been in 80 to 89-year-olds. But in the last wave, we've seen deaths, quite a few deaths above the age of 65, so in 65 to 80-year-olds. And this is in comparison to the UK. I couldn't get 2 graphs that have the same shape, so I'm sorry about that. But I think that it's more or less the same shape and more or less the same ratio of males to females dying with an increased rate of death among, or proportion of deaths among men, similar to the UK. But you've had some deaths in children. I don't know how old they were. And we've, as I said, had maybe 1 or 2 at age 19. Okay, school closures and the epidemic curve. So if we look at that first wave, schools were open and then they were closed. I don't think that anybody blames little children on the first wave. The second wave, many people thought that it was due to school reopening. But I think I showed you on the last or 2 graphs ago that many other measures were put in place when schools were reopened in May and June. And that included opening wedding halls and restaurants. And then we had this sort of neglected wave over the summer. Some kids were in school in July, but most of this increase in infection cannot be attributed to schools. And then we sent the kids back to school in September, and we see this huge wave of surge of infection. And the popular wisdom, the common wisdom was that it was due to school reopening, and I would like to address that fact soon. I can't ignore this huge outbreak that happened in the Gymnasia Rechavia school. This is a middle school and high school in Jerusalem. It's a secular school. It's probably one of the most crowded schools in the country. The class sizes are 35 to 38 students on average. The area that's given per desk and per student is very, very low, much lower than the OECD stipulates as a standard. There was no social distancing among students when this outbreak took place. It happened in a heat wave, 40-degree heat for 10 days. It was so hot that the health minister said that the students don't have to wear their masks because it was so hot. And windows were closed, so there was no ventilation. Air conditioning was active, and so we had this huge outbreak of hundreds of students and teachers and family members. I think altogether, 225 people were infected by this in this outbreak, which was probably a concatenation of 2 super spreader events. one of them most likely from a teacher that traveled from class to class. So this teacher didn't just teach one class, and therefore was able to expose scores of students to the virus. What's interesting about this outbreak is that it really was very well contained, because the district health office, and this is Henstein Zamir, who's a colleague, and the Jerusalem district health officer, they really did a fantastic job going into the school and then opening up testing for all the students, the teachers, and their families. So they actually broke the accepted criteria of the health ministry at the time, which had to do with symptoms, had to do with return from abroad, very strict criteria for testing. And Professor Stein-Zamir said, no, I think we need to test everybody. And they did. They tested all the students of the school within a couple of days, and whatever family members needed to be tested, and teachers. And this terrible outbreak was contained and did not spread into the community. Okay, this third wave now, the governance is a little bit different. We still have the same prime minister, but the prime minister hired Professor Gamzu, the same one who set up the Protect Your Mothers and Fathers, or Shield Our Mothers and Fathers program for the long-term care homes. He hired him as what's called the projector, or the SAR of COVID. It was a long time coming, because there were other people who were being interviewed for the job who actually refused to take it because they weren't sure what their actual mandate was going to be. But he was asked and took the job right away. He's a very energetic guy, as I said, a hospital director. And the first thing he did was he spoke to the populace, and he said, this is a problem of all of us. We all have to take our part. We all have to behave. We have to keep our distance. We can do it. It was a kind of motivational talk. And then he sat and looked at the data, and he decided that the best way to handle the epidemic was using what's called a traffic light system. And the traffic light system means that they're differential and geographic, and this should speak to the UK audience, that there should be differential measures based on geography and based on population rates of disease on a local scale, to the point that there could be local lockdowns, and there could be places where schools are 100% in business, and other places where schools are not open at all. This was met with a lot of opposition because these are not just geographical issues. Geography and politics and ethnicity and religiosity go together, because certain towns are almost 100% ultra-Orthodox, other towns are almost 100% Arab population. So this traffic light system had ramifications that were political as well. And so there was a lot of foot dragging, I think almost 5 or 6 weeks between the time that it was proposed and the time that it was approved. But by the time it was approved, we already had this huge surge of cases, and it basically became irrelevant. In the background, we also had some other political international events, like the signing of a peace accord with the United Arab Emirates, which it was a very happy occasion, but also had ramifications for the management of COVID, because you can see these people are not wearing masks, but also our Prime Minister went with a contingency of people who came back, and according to the rules should have spent almost 2 weeks in isolation or in quarantine when they came back, but when they were found wandering around the country within 2 days of returning from their trip to this happy occasion. So again, we had issues of trust. And this is our our third wave. You can see the people hospitalized in moderate or severe condition with this rise in September. It did happen after school opening, but we're going to address that in a second, whether we think that was the cause. What happened in early September, around the 8th, 9th, 10th of September, was because of this rise of moderate and severe cases and a rise in cases requiring ventilation, the hospital directors around the country started to scream. And they held a press conference and they said, we're being crushed. And we see scenarios like in Northern Italy, just around the corner. So please do something. And the response to the please do something was to have a lockdown. And so schools were closed around the 16th, and from the 17th of September, we had a lockdown. What was happening just before this lockdown was a summer of discontent or content, depending on how you look at it. A lot of demonstrations and a lot of controversy about how much of these political demonstrations against the Prime Minister, asking for his departure from government, but a lot of controversy about how much these demonstrations contributed to the increased infection rate in early September. Over the summer was the wedding season in the Arab population, and we saw a huge number of nightly weddings with hundreds and hundreds of participants, and no social distancing and no mask wearing, and a big surge of cases in Arab towns and villages. And of course, a lot of gatherings in the Haredi population. This is just one example of a funeral. And then in late August, there are no summer camps open in late August. There's no schooling in late August, so families are on vacation, and we see crowding around beaches. People went to hotels. So just like the Gymnasia Rechavia was a perfect storm for a school outbreak, I think what happened at the end of August was a perfect storm for a national outbreak, or the third wave of infection. A lot of people, including some people in our government, have blamed school opening for this third wave. So I would just like to take you through 3 school systems, which are separate school systems administratively: the ultra-Orthodox sector, the general sector, and the Arab school sector, and what was happening in terms of COVID morbidity. These are confirmed cases per 100,000, and the different colors are different age groups. These colors down here are the very young kids, 0 to 2 and 3 to 5 and 6 to 8 years old. The black are adults, 24 to 120 years old. And the pink, green, and red are teenagers and young adults. So in the ultra-Orthodox sector, the schools or the yeshivas opened at close to the end of August. 10 days later, we see a huge surge of infections, hundreds of cases per day in this sector. And if we look more closely at it, there's a sex differential. So we see that this big surge was in the young boys and not so much in the young girls, and it's in the late teenage years. And what happens in the late teenage years in the ultra-Orthodox sector is that they go to yeshiva. They have it's a boarding school environment, very close quarters, and there was really a massive outbreaks in these yeshivas in late August, early September. The problem was that every couple of weeks, these boys would come home. And so this was supposed to be contained within the yeshivas, but it actually wasn't contained. And people also went in and out during the day, visiting, and some of them went out in the evenings. So this is what happened in the ultra-Orthodox school system. If we look at the Arab school system, schools opened in the beginning of September. These are the very young kids, the blue, the turquoise, and the orange, and then the 6 to 8 year olds and 9-year-olds. So we see that there was a rise in cases in the children, but the young children were relatively spared. The teenagers had quite a bit of rise in infection, but the main, I'd say, engine of infection in the Arab population was in the older age group, the 24 to 120 years old, in other words, in the adults. And what was happening in the community among the adults was then being reflected in the school age population. In fact, as they stayed in school for the first couple, after the first week in school, the rates of infection actually went down in children instead of going up. So I think that this is a really classic case of looking at what's happening in the community. Rates of infection are increasing in the Arab population in the community over the summer months, probably because of these frequent and largely attended weddings. And this spilled over to the children who had increased rates after school opening, but after they'd been in school for a week or two, the rates actually went down. And in the general population, we see that the rates went up as of September 1st. So anyone who claims that school opening caused the rate of increase in the population doesn't really understand how an epidemic works. We have to look backwards to 10 days, at least a week or 10 days or 2 weeks before, and see why these rates were increasing in this population, and probably because of family gatherings and hotels and social gatherings among teenagers. Once again, we see the very young kids, the orange and the turquoise relatively spared, and the teenagers having a high rate of infection. So these are the 3 waves. Now it looks like the first wave was really very, very minimal compared to what happened later on. This is over the summer months, that second wave, which I'd say was not really managed. There weren't really any major measures that were put in place, and we just sort of passively watched the numbers going up. And then when it became very, very clear that there was a surge, and the hospital directors say, you know, we're in trouble here, we may not be able to manage this, we might have scenes like in Italy, then the lockdown was put in place here around the 17th of September. And 2 weeks after that, we see a decrease in the number of cases. And this is the daily deaths over the 3 periods. We're starting to see a decrease now, but we still have daily deaths in the double digits, which we never saw, we almost never saw in the first wave. The other thing that's happened relating to governance is that some groups in the population are really not paying much attention to the measures. Schools are supposed to be closed. Only kindergartens have been open for the last 10 days. Schools are supposed to be closed until next Sunday, and then grades 1, 2, 3, and 4 will be back. But in certain towns and in certain populations, they have opened their schools. Some of them are being fined, and some of them are not being found out, so they're not being fined. So unfortunately, we have a situation of almost having a country within a country, and some of the laws and the rules are not being followed. And that's causing a lot of anguish in the population. And this anguish in the population is being expressed in demonstrations. And when demonstrations were banned during the lockdown, because we weren't allowed to go, we weren't allowed to travel more than 1 kilometer from our house during the lockdown, these became local demonstrations. So you would see on bridges and on street corners in every neighborhood, a bunch of people demonstrating 3 times a week. Also against the lockdown measures, but mostly against the government and its governance. We have very, very little consensus in our society right now. We don't have consensus among our health experts. Some of them publicly were against the lockdown and were very vociferous about it, much to the dismay of the health ministry, who thought that everyone should pull together, and especially physicians, and say we need to have this lockdown in order to protect the population. We've seen a huge disproportionate number of cases among the ultra-Orthodox because of crowding, because of having mass events, whether these are religious events or celebratory events, despite laws and measures. And we've had, and this is a group that I'm part of. This headline says, experts panned fundamentally flawed ministry report that kids are super spreaders. This was a report that came out a week ago from the Ministry of Health that we thought was blaming children for the third wave or the second wave of this epidemic, which we thought was not responsible, tendentious, and not based on the data that we could see and that we could interpret. So this lack of consensus bodes, I think, poorly for the next phases of this pandemic, because we really see a lot of fractures in the population. Having said that, a silver lining, and I think the healthcare system, the health system response in Israel has really been commendable. There's been a huge amount of community care for COVID cases, either in hotels where certain patients have been taken to hotels and cared for there, but at some point 30, 40, 50,000 patients being cared for in the community by the health maintenance organizations, with home oxygen saturation monitors and phone calls once or twice a day, and really a commendable community management of this epidemic. A lot of use of telemedicine, volunteer services, providing food and medications for people stuck at home. A lot of increase in testing, to the point where the government is saying, now please come and be tested because we think we're under testing now. Data systems in hospitals to monitor COVID cases, especially since so much of their care is semi-remote. Very few people are actually going into these hospital wards. And this is a survey that was carried out among the anesthetists in Israel. And they also saw that, there was a silver lining, that this epidemic was going to provide them opportunities to purchase new equipment, to train and improve their clinical capabilities, to undertake technological innovations. And mainly they did not suffer from a lack of personal protective equipment. So I think from the point of view of clinical care, probably there have been improvements during this COVID crisis. We have had what we've seen everywhere in the world, the collateral damage of people delaying care, not coming for screening tests, delaying coming to hospital with acute illnesses. That's another aspect that I'm researching right now. We never had a message like you had, stay at home, save the NHS. We did have a message, stay at home, but it wasn't explicit that this was to save the healthcare system. And I think that's something that we can maybe discuss, whether that explicit request to stay at home in order to save the healthcare system is an appropriate message when we believe in health as a right. So right now we can be a little bit optimistic. We seem to be turning the corner. Our R value went up from a peak of 1.55 in September, and around the 17th of September, it's now 0.6 or 0.8. The percent of positive cases, which peaked at almost 15%, now is down to about 3% or 2%, which is good. When it was 15%, just just to pique your curiosity, in the ultra-Orthodox towns where people were tested, we had 30% positivity among those tested, which is really, really, really high. But we are going to be living with the consequences of these measures and this lockdown for a long time. Israel started with an unemployment rate of 3.9% before the COVID crisis, and we're now at around 25%, about 1 million people or more unemployed. And so these are going to have grave consequences, not only socially, but also for population health. The big question is how we're going to exit the current wave. I think that everyone's learned that in the race between the rabbit and the turtle and the hare, the turtle is going to win this time, and it's going to be a much, much slower exit. But the consequence of this slower exit is that a lot of small businesses are going to fall and fail completely and never going to be able to reopen. And that's going to have consequences for cities and municipal areas. In terms of governance, Ronnie Gamzo is going to finish his volunteer projector job in the next couple of weeks. And just today we got word about who the next czar or projector is going to be, and also a very, very competent person. Our Prime Minister has other fish to fry and other issues on his agenda. The question is how much he should have been involved in the first place in the management of this epidemic. He's been extremely involved, and how much of it should have been given over to the professionals to manage. So I think that the next few weeks and months are going to be very, very interesting to see how we exit, and it's going to happen at the same time as Europe is experiencing its major second wave. Just to give a little bit of historical perspective, this is obviously not the first pandemic ever to hit the world, but it's probably the worst one since the influenza pandemic of 1918. And there, if we look back, we can see that also the speed at which measures are undertaken. And this is the city of New York, which rapidly, the square here is basically the lockdown or the quarantine measures. The city of New York rapidly instituted quarantine measures, and it had a surge, but it wasn't that high, and it was a little bit broad so that people could be cared for. Not that they had a lot to do in 1918, they didn't have antibiotics, they didn't have ventilators, and they didn't even have oxygen. But we see this broad epidemic peak, whereas Philadelphia took its time instituting these quarantine measures and experienced a huge surge, the biggest one in the United States, probably because of this delay. And I think that has probably some parallels between Israel and the UK when we look at the first wave. But I think for Israel, the place that seems to be most parallel is St. Louis, which instituted its measures relatively early, but released them relatively early as well, and said, oops, as they released their measures, they started to experience a second wave. So this is what we see in history, and I think that we're seeing similar patterns now, and I'm not sure that we can learn as this epidemic is unfolding, whether we'll only learn as we look back, or whether we can be learning online in real time remains to be seen. So I'm going to just wrap up with a few words. Sadly, I believe that history teaches that history doesn't teach. I don't think that we learn much we've learned much about how to handle this specific epidemic by how we've handled previous ones or how we even handled the first wave. There's no question that COVID has exposed the fractures in society, in every society, but especially in Israeli society. It's also exposed the vulnerabilities of the health system. I think Israel is coming through not badly in terms of the health system, but it is vulnerable. All of us, whether it's the population or the politicians who are making decisions, I think we're only prepared for a sprint, not for a marathon. As I said, they handled the first wave as if it was a event of Holocaust proportions, which it was not. And then it made them kind of complacent for the second wave. And then the third wave again, people were tired and not happy, to say the least, to comply with government measures. We need to have humility. We need to have trust, which is sorely lacking in our society. And we obviously need to have leadership. We need to have leaders who can make quick decisions, but also slow reversals of those decisions. It's a tragedy what has happened to our children in our society. They have been the major victims of the management of the COVID epidemic, even though they are minor victims of the disease itself. And I see what's happening around the corner, so I wish you all very good luck with the coming COVID winter. Thank you.
Muted myself. Thank you very much. And really, that's a remarkable overview, taking into account both countries in a quite extraordinary fashion and showing some lessons very clearly. There's one question that, one immediate question that came up immediately, which was the question of testing. That we hear about variety of rapid diagnostic testing and in Israel. Are any of them going to be of any use here? And when, how can they be introduced? Or how, when and how were they introduced, and can they be introduced? Because the testing system over here seems to be a major problem.
So we have these tests, the Sophia tests, which take about 15 minutes. All the health, the HMOs have them. The problem with those tests is that they are, they work best for people who are symptomatic. So the sensitivity is about 80% for people who are symptomatic. And so it's a way of saying, yes, you have symptoms, and we now confirm that you have the disease. The problem is that you have to end up doing the regular PCR tests for people who are negative. And so you haven't saved all that much, because the people who are symptomatic, you know, they could have self-isolated and had their tests at some point during the day or the next day. If it really is going to work, it's going to work as a red light, green light system. And I think we're not there yet. If we could have that work, then we would be much more comfortable opening schools for teenagers, which we haven't done yet. Right now, we're opening schools for, we've opened the kindergartens, and the decision to open the kindergartens was made on a Thursday. The kindergartens were to be opened on Sunday, and they said to the kindergarten teachers, come and get tested. Of course, only a few hundred managed to get tested before schools opened on Sunday, but basically the door was open for them to be tested. And now I think one lesson has been learned, that we're Tuesday, last night, the decision was made that schools grade 1, 2, 3, and 4 are going to be open on Sunday. So already today, the teachers who teach those classes are being asked to be tested by the regular PCR, not by the Sophia. So, I mean, hopefully we'll have a good rapid test soon. But what we have right now, I don't think it's good enough, because it just seems to work best in symptomatic cases, which is not good enough. Those people should be staying home anyway, not going to school.
Right. Then another question is really, if on balance, would you say that the UK had a bad start with the failure of the initial lockdown, but subsequently is not done too badly by comparison?
It seems that way, although I think that the excess mortality is something that, you know, that there's a huge amount of excess mortality in the UK.
Yeah.
So that's something that you have to come to terms with. But since then seems to be doing better. And also you have a fantastic Royal Academy of Pediatrics, which has come, so clearly said that children have to go to school and what are the conditions that they need to go to school. So I envy that because we haven't had such a clear message here. We've tried very hard and hopefully we've succeeded in some way. I think it's shocking that a country that says that it loves children so much has really let them decay in such a terrible way over the last 8 months.
The other thing is,
there's a question here in the Q&A. Have you not seen this pediatric inflammatory syndrome in kids in Israel that we've seen a lot of in the UK? So we have seen it. There's a controversy about how many cases that the pediatrics, the equivalent of the Academy of Pediatrics has collected hospitalized cases, and they came up with a number of 20 cases. But yesterday I heard that even in Hadassah, there have been 20 cases. So there probably have been between 40 and 80 cases of this inflammatory syndrome in Israel. No one has died from it. A couple of kids have been in the ICU, a few kids, I think 3 are in the ICU right now in Beersheba. They've all survived, most of them with few sequelae. They're treated very quickly with, IVIG and other things, and they seem to have done well.
What about the nursing home question? What are the attitudes that lead to admission of elderly patients, and how to compare whether there's suggestions that elderly patients at the best of times don't get admitted, but this was worse under these circumstances?
Yeah, so I don't think we have that phenomenon in Israel that I've seen in the UK and especially in Sweden. I mean, I think if you look at the numbers in Sweden, like nobody over the age of 90 was admitted to the ICU, and 1 or 2 people over the age of 80 were admitted to the ICU in that first wave. In Israel, if an old person, even from a nursing home, is very sick and requires ICU care, they're going to be admitted to the ICU. So no triaging had to be done, and no triaging was done during that first wave or even in the second wave. But what was done was a lot of testing of the staff, a lot of quarantining within long-term care institutions, even for months on end, which was a problem because loneliness, people were stuck in their rooms. There were very strict visiting measures and things like that. Somehow it was handled, but we still have a third of the deaths are nursing home patients. So I think, we can't say we've gotten off scot-free from that point of view either.
And there's a final question. We'll just take the final one about antibody testing. Negative when people have antibodies. It's been high on the news today in the UK because of the reported fall in antibody levels. So what about the antibody testing? And if you have antibodies, would you say people could go back to work or go back to schools?
Okay, so we have antibody tests where there was a serological, I refuse to call it a survey because, well, it was a survey, but it was not a representative population-based survey. The Ministry of Health instituted a study, but they did not put in the requisite resources to make it a real population-based survey, so we would know the serology of COVID in Israel. What they did was they said most people in Israel come to the HMO at least once a year and have a blood test. So we will sample those people who are coming anyway to have a blood test. And there was some kind of systematic sampling of different cities in Israel, different population groups and everything. And that will give us an idea of what the seroprevalence is. But it turns out that there was undersampling of many regions in Israel, and there was definitely undersampling of children. So the survey came out with a population rate of about 7% seropositivity in children. We don't believe that, because we don't believe that children who have blood tests are in any way representative of children in the country. Most children never have a blood test. Whether having antibodies means you're protected, probably you're protected for a certain amount of time, but we don't know at what point in the waning of the antibodies you're no longer protective, either for yourself or for other people. And I think that the number in Israel of confirmed recurrent cases is huge. I mean, there was a case in Hong Kong and another case here. These were case reports. We had a first case report in Israel a couple of weeks ago, and now the number is something like 81 cases of confirmed reinfection with COVID. And this is, in an eight-month period. So people can definitely get reinfected, and people who have antibodies can get reinfected. And as I said, we don't know at what point of the antibody waning there is a danger to the person or to society. So if it's right after, probably we can assume, that it's safe, but not for the long term.
I think, Ora, it's now 11:30 Israel time, and you've got to get to work.
Okay, just somebody asked me here, I see in the Q&A.
Yeah.
There's a COVID case in their class. The whole class is quarantining for 2 weeks. Does this make sense given that kids don't transmit the virus? Well, I wouldn't say that kids don't transmit the virus. Kids probably do transmit the virus, but probably less. We know that kids under the age of 9 or 10 transmit less than over the age of 10. This is from several studies, but especially a Korean study in households. 11 years old is really on the borderline of almost being 12 or 13. So I'd say, if there's a COVID case in her class, she has to quarantine for 2 weeks.
Really, I think, kind of we should let you get back to
Now I'm perfectly wide awake.
Okay, now we've woken you up. Well, you've certainly given us lots to think about, both tonight and for the days to come. And this is just to thank you very much, not only for the way you've done this and the way you've done this willingly, but also for the huge preparation that you've had to do matching between Israel and the UK for a talk like this. So thank you very much.
Thank you,
everybody. And I'm sure I'm sure there'll be more questions which people can send in, and we can pass on to you if that's okay.
Sure.
Thank you.
Okay, thank you.